Small cell lung cancer is a little different than non-small cell. It's historically quite aggressive. It's unforgiving, in fact. So there is an urgent need that once we make a diagnosis and there's been a formal pathological assessment that this is indeed small cell, that we are mindful to get treatment started right away. I think with non-small cell lung cancer, we have a little more time. Sometimes it's not as rapidly growing and we have to wait for molecular markers. With small cell, it's a little different. I think the goal is to make a diagnosis rapidly and then get the patient on the right regimen. There are no molecular markers we're waiting for, and all patients should receive some sort of platinum-based with etoposide or irinotecan chemotherapy regimens with now, of course, immunotherapy. But the game is a little different. There's an urgent need, and we need to be mindful for formal staging. We need to do an MRI of the brain, but we need to get going with platinum-based chemotherapy with immunotherapy as soon as possible for these patients. Oftentimes, that occurs in the hospital. Patients are admitted to the hospital for clinically decompensating from their small cell, and we oftentimes start chemotherapy in the hospital for these patients, which is one of the few types of thoracic malignancies that we will start chemotherapy in the hospital because patients do get better in a rapid fashion after chemotherapy. So we've tried many times to improve the outcomes for patients with extensive stage small cell. Multiple different strategies have been employed. They've looked at adding a third drug, a chemotherapy drug, to the two drugs that already exist with platinum, etoposide, or irinotecan. They've looked at novel vaccine therapies. They've looked at maintenance therapy. All of these trials, unfortunately, have failed. Some of these have had uptake in other malignancies, but we've learned that this is a recalcitrant and a very difficult tumor to treat. And this is why it's so exciting to see for the first time an advancement in the outcomes for patients with small cell lung cancer with the advent of immunotherapy. We've waited a long time. 1985 is really where platinum etoposide was a standard of care for first-line treatment for extensive stage small cell, and we've waited quite a long time, 35 years or 34 years, to make an advancement with the advent of immunotherapy. So the strategies of adding new drugs, high-dose chemotherapy, maintenance strategies, particular targeted therapy agents have all failed. For the first time, immunotherapy has really moved the needle. Small movement in the needle, but a movement nonetheless that we should be excited about. Yeah, so for patients with extensive stage small cell lung cancer, we need to remember that, of course, we're trying to treat them with these novel immunotherapies, with chemotherapies, but we need to also institute supportive care for these patients. And this really just mirrors the supportive care that we offer for all of our lung cancer patients. We want to make sure that their pain is controlled optimally. We want to assess their appetite and make sure that their appetite is addressed. Obviously, cough and shortness of breath are quite common in small cells, so coming up with regimens that we can institute that help with that. And then remembering that, small cell is a smoking disease, and we try very hard to institute smoking cessation. I think it's important for patients with extensive stage small cell lung cancer to have discussions about goals of care. We always try to have a formal evaluation by our supportive care team at our institution. So having those conversations in parallel, we can treat you, but at the same time, there's supportive care needs that we need to address and be mindful of.